Archana ma'am, shall we start?
Yes, sir.
Okay, ma'am. Thank you. Uh, a very good afternoon to all of you. On the behalf of Academy of Rog Nidan, I, Dr. Ganesh Kolle, welcomes all the dignitaries. Today's our speaker. Uh, Not only speaker, rather I will say that very student-friendly teacher, Professor Archana ma'am. Professor Archana Gharge ma'am is currently working as professor and HOD in Rognidan and Vikruti Vigyan department at YMT Ayurved Medical College, Kharghar, Mumbai. Ma'am has completed UG from KG Mittal Ayurved Medical College, and she has completed his post graduation in Kai Chikitsa from Aripoddar Medical College. Ma'am has total academic experience of 20 years, and she is also a PG guide and PhD guide. 9 students have completed their post graduation degree under ma'am's guidance, and currently 3 PG students are under his guidance. Ma'am is also doing PhD at DMM Ayurved College, Yavatmal, under respected Mundane sir's guidance. Till now, ma'am has published 20 scientific papers in various peer-reviewed journals, national and international journals. Ma'am has been a keynote speaker to various seminars. So today's topic for ma'am's is a very important topic in the perspective of Ayurveda, because many patients complaints Ayurved को जोड़ के देखते हैं संधि शूल इसके साथ, तो हाउ टू डिफरेंशिएट between Sandhi shul as a amwat or any as ma'am says. So I request respected Professor Archana Gharge ma'am to start her lecture. Thank you, ma'am. Archana ma'am, over to you.
Okay, sir. Thank you very much for my kind introduction, Kule sir.
Okay, ma'am.
Good afternoon to all on this virtual dais. Can you hear me?
Ma'am.
Hello, sir.
Yes, ma'am. Yes, ma'am. You are audible.
To all on this virtual dais. Yes. I thank to all the respected members of the Academy of the Rog Nidan, our respected President Dr. Pawan Kumar Godadwar, Secretary respected Dr. Atul Vaishnav sir, and the convener Dr. Ganesh Kolle sir, then all the faculties of our Ayurveda field, the students, and especially thanks to Dr. Ganesh Kolle who approached me again 4 days back to deliver a lecture in this academy, and the academy gave me this opportunity. Thank you very much to all our respected seniors and all listeners also who are going to bear me today. Okay. So, sir, my today's topic is differential diagnosis of the Sandhi shool with special reference to the diagnostic tests. First of all, I will go over Lord Dhanvantari, the Lord of Ayurveda, and then I will start my lecture. Slide share is not possible, so may not be, the slides cannot be visible. Okay. So today's our topic is Sandhi shool. So Sandhi means we are related with the joint diseases. So first of all, we should know. Can you see slide, Ole sir?
Yes.
Ole sir.
Yes, ma'am.
Can you see the slide, current slide, anatomy of joint? This one.
No, ma'am. I am seeing your first slide. Hello.
What to do to share all slides? Only I don't understand.
Yes, ma'am. I can see the first slide.
Other slides. Just a minute, sir.
Yes, ma'am. Yes, ma'am. Now it is. We can say anatomy of joint. Sorry.
Okay, thank you, sir.
Thank you.
So first of all, we must know about the anatomy of the joint. So when two bones make a joint, The surrounding structures are the cartilage, synovial membrane, ligaments. So cartilage basically it is a type of tissue which covers the surface of the bone at the joint, and it helps to reduce the friction of the movements of two bones in a joint. Okay. Then second part in the joint is synovial membrane. It is a tissue which lines the joint and seals the joint capsule. And the main function, actually, the synovial membrane is a very clear, sticky fluid, and it surrounds the joint and lubricates it so that the movements of the joint are very easier. The ligaments surround the joint. These are the connective tissues surround the joint to give the support and limit the joint's movements. And ligaments help to connect the bones together. The tendons also play an important role in the joint structure because they control the movement of the joint and they connect the muscles to the bones. The bursa, these are also fluid-filled sacs between the bones, ligaments, and the nearby structures, and they help as a cushion to avoid the friction in the joint. Then the synovial fluid, it is a clear sticky fluid secreted by the synovial membrane, and the meniscus, it is a curved part of the cartilage in the knee and the other joint. So when we learn about Sandhi shool, Sandhis are the joints, and according to the Ayurveda, Sandhi shool is the chief symptom which is seen in the many diseases such as Sandhivat, Amvat, Vatarakta, Kroshtok and Asti Majjagat Vat. As a chief symptom, it is seen in these diseases. Apart from these diseases, it can be seen in other diseases also. So first of all, Sandhigat Vat is very important disease. Important means many cases of Sandhigat Vat we have to deal with in our OPD and IPDs. And second thing, it is very common disease which is occurred in the aged persons or the patients above the age 40. Okay? So the description given in Ayurveda about Sandhigat Vat, or we can say the Nirukti of Sandhigat Vat is Hanti Sandhigatah Sandhim Shula Atopau Karoti Cha. Means actually it is mentioned that there is destruction of the sandhis with shool and atop lakshan. Shool means sandhi shool, that is joint pain, and second is atop at the joint, that is the, we can say, joint crepitus. So these symptoms are told about the Sandhigat Vat. When we think about the lakshanas which are mentioned in the Charak Chikitsa Sthan of the Sandhigat Vat, it is mentioned that Vatapurna Kruti Sparshah Shodha Sandhigate Nile Prasarana Akunchanayoho Pravrittischa Sa Vedana. The symptoms which are mentioned in Sandhigat Vat are joint pain, that is Sandhi shool, swelling of the joint, Shodha. It is present sometimes or it may be absent, not necessarily. In every case of the Sandhigat Vat, Shodha is there. And the next symptom which is mentioned is the joint pain, which exaggerates especially during the movements. Mainly means during prasaran and akunchan. Prasarana akunchanayoho pravrittischa sa vedana means during prasaran, akunchan, flexion and extension of the joint, the vedana lakshan is exaggerated or it is severe during the movements. When we see the types of Sandhigat Vat, we should know that in Granthas, Vata Prakop, the causes of Vata Prakop are mentioned. Two main causes have been mentioned, that is Vayoho Dhatu Kshayat Kopo, Margasya Avaranena Cha. Vata Prakop or vitiation of the Vata Dosha is caused due to two main causes, that is one is the Dhatu Kshay and second one is the Margasya Avaranena Cha, that is Margasya Avaran, or we can say it as a Margavarodh Janit Vata Prakop. So first one is Dhatu Kshay Janit, in Granthas it is mentioned as Nirupas Stambhit, and second one is the Margasya Avaranena, that is Margavarodha Janit Vata Prakop or Upastambhit. Upastambha means Avrodh. And in Dhatu Kshay there is Vata Prakop due to many reasons, that causes dhatu kshay, we can say we can call it as degenerative uh, diseases of Vata or degenerative changes occurring at the joint. And second one is the Margavarodha Janit Vata Prokop, in which Vata dosha is vitiated due to the obstruction in its path by Kapha and Pitta dosha. So these are two mainly reasons that causes Vata Prokop, and accordingly Sandhigat Vata. Next disease in which Sandhi Vedana is very commonly seen is Vata Rakta. In Vata Rakta, it is mentioned that Tasya Sthana Karo Pado Angulyah Sarva Sandhayah. So it is mentioned that all the joints related with the hand, legs, and fingers are suffered or get affected in the Vata Rakta Vyadhi. And the next line we can say Karote Dukkham Teshu Eva Tasmat Prayana Sandhishu. The Sandhi Vedana is a very common symptom in Vata Rakta, that too in the grade 2 is Angushtha Moolasthane Vedana, then Dahavat, that too Dahavat Vedana. It is mentioned that in Vata Rakta Mushaka Damshavat Vedana is there. Mushaka Damshavat means like pain like the bite of the mouse. It is so severe and it causes the redness of the joint, and basically it starts with the grade 2, that is the Angushta Moolasthana. And the many symptoms which are mentioned in the Vata Rakta or gout are intense joint pain, lingering discomfort, inflammation and redness of the joint, and limited range of the motion. So the next disease in which Sandhi Vedana or Sandhi Shul is a prominent symptom is Amavat. Amavat is a disease which is caused due to the vitiation of the production of the arm and vitiation of the Vata dosha, and combination of arm and Vata causes Amavat disease. So specially special lakshanas which are mentioned in Amavata are Yugapat Kupita Vantas Trik Sandhi Praveshako. Means there is pain in the Trik Sandhi. Trik Sandhi means the sacral joint, lumbosacral joint, we can say. Even if Trik Sandhi is mentioned, there is pain in other small and major joints also. So we can correlate with the rheumatoid arthritis, and the symptoms which are mentioned in the rheumatoid arthritis are pain in the more than one joint, stiffness in more than one joint. Means Sandhi Shul is there, along with that stiffness means generally morning stiffness is there. Sandhi Graha Lakshan is very important in Amvat, and by that Lakshan we can differentiate Amvat from the Sandhigat Vata and Vata Rakta also. So there is tenderness and swelling in more than one joint, symmetrical joint pain, weight loss, fever, fatigue, and weakness. So the joints which are involved in rheumatoid arthritis are symmetrical. Okay, and such kind of symmetry is not seen in osteoarthritis. Next one is Asthi Majjagata Vata. It has been given that Bhedoस्थि Parvanam Sandhi Shulam Mausavalakshayah Aswapnah Santata Rupcha Majjasthi Ite Nile. In Asthi Majjagat Vata, we get the symptoms Asthi Parvanam Sandhi Shulam, that is joint pain, then Mausakshay, Palakshay, and insomnia. So up till now we have seen all these diseases in which Sandhi Shul or Sandhi Vedana is very common symptom. Next disease which is dealing with the Sandhi Vedana is Koshtuka Shirsha. In Madhav Nidan Vatavyadhi, the lakshanas which have been mentioned regarding Koshtuka Shirsha are Vata Shonitajaha Shothu, Janu Madhe Maharujah, Neha Koshtuka Shirshastu, Sthulaha Koshtuka Shirshavat. So Shotha Janu Madhe means the pain at the knee joint. This is the chief symptom in the Koshtuka Shirsha, and this knee joint pain is mostly unilateral, or it may be bilateral if the infection is in the both knee joints. Okay. So there is knee. Hello. Hello, sir. Am I audible?
Hello, ma'am.
Hello,
Hello.
sir.
Ma'am. Yes.
Am I audible?
Yes, ma'am. But sometimes your voice is breaking.
Sir, there is connectivity issues. That's why.
Okay. Okay. No problem. No
Okay,
issue.
sir.
Okay.
So in Proshtukshirsha, there is knee joint pain, swelling of the joint, and there is also the change in the shape of the joint. It is like the Proshtukashirsha, means head of the box. So this was all about the Ayurveda. Hello. Hello, sir.
Yes, ma'am. Hello.
Okay.
Hello.
Shall I continue?
Yes, ma'am.
Okay. So this was all about the Ayurvedic diseases which are dealing with the Sandhi shool. In our OPD, IPD cases, many patients come to us with the symptoms, Sandhi, Vedana or joint pain, and that time we have to differentiate that what kind of joint pain it is. Either it is due to Sandhivat, Amvat, Vatarakta or Proshtukshirsha. Okay. So for that we have the differential diagnosis that uh, according to the symptoms, we can differentiate them. We have to do the examination of the patient and also the different investigations. And in investigations, we have to do the pathological investigations as well as radiological investigations. So we will come to the modern differential diagnosis of the joint pain. So when we think in the modern way, there are so many types of arthritis, that is osteoarthritis, rheumatoid arthritis, rheumatic arthritis, gouty arthritis, psoriatic arthritis, ankylosing spondylitis, SLE, tubercular arthritis, reactive arthritis, which is also called as Ritter's disease, and Lyme disease. So commonly we deal with osteoarthritis, rheumatoid arthritis, and gouty arthritis cases. These are very commonly seen cases. Rheumatic arthritis is rare and it occurs in the either it is juvenile or it is seen in the children which are below 15 years age. Okay, and the other ankylosing spondylitis, SLE, uh, reactive arthritis, these are all autoimmune diseases in which joint pain is seen specifically. So those all diseases also come under the differential diagnosis of the diseases which have severe joint pain. Okay. So this is the classification of the joint disease. Basically, there are two types of pathology. One is proliferative pathology and second is erosive pathology. In proliferative kind of pathology, osteoarthritis disease comes. In osteoarthritis, there is the degeneration and proliferative changes at the bone or joint and causing the uh, destruction of the cartilage and synovial fluid inflammation. Okay, and the erosive kind of pathology is seen in erosive osteoarthritis, rheumatoid arthritis, gout, and some seronegative types of arthritis, which contain ankylosing spondylitis, reactive arthropathy, psoriatic arthropathy, and enteropathic arthropathy. So there are mainly, as in Ayurveda, there are two main causes of Vata Prabhu, like Dhatu Kshay and Margavarod. In modern, these all joint diseases or all arthritis are classified into two main pathologies, that is proliferative and erosive. So first, we will see about the osteoarthritis. It is a degenerative disease of the synovial joints, which is characterized by the focal loss of the hyaline cartilage with the proliferation of new bone and remodeling of joint. So due to the proliferation of new bone and remodeling of the joint, the osteophytes start producing in the joint. So in the X-ray images, we can see as a result of all this proliferative pathology, we can see the bone spurt or osteophytes in the X-rays. This is also known as the Pear and Tear arthritis. Osteoarthritis a gradual breakdown of the cushion on the end of the bones, which is called as cartilage, and it is mostly diagnosed by the X-ray and MRI. And the joints which are involved in the osteoarthritis are mostly knees because it is a weight-bearing joint. The other joints are the joints of the hand, hips, spinal joints, and in all these joints, the cartilage acts as a cushion of the forces that are put on the joints of the body, and this cartilage destruction is mainly seen in the osteoarthritis. So osteoarthritis occurs when the cartilage gradually deteriorates. It is a firm, slippery tissue which enables nearly frictionless joint motions, and even if the cartilage wears down completely, the two bones will rub and they will cause pain. Okay. So in this image, we can see that there is thinning of the cartilage is seen. The joint capsule has been stretched and thickened. The bony spurs and osteophytes are seen at the edge of the bone, and the synovial membrane, synovial fluid has the tissue content, so there is synovitis also, inflamed synovium is seen. Then this image shows us that in chronic osteoarthritis or in the later stages of the arthritis, there are some complications which are seen in the joints. Those complications are the fusiform swelling of the joint, then changes in the shape of the fingers, and Heberden's nodes, which can see at the joints of the fingers. Okay. So it is a joint disease which is seen in middle-aged to elderly people, and it is characterized by the minimal articular inflammation. Progressive damage to the articular cartilage is seen, thickening of the subchondral bone and the joint capsule is seen, and there is a formation of the osteophytes or the bony spurs, and mild synovitis also is the main symptom in the osteoarthritis. Now we will see about the pathophysiology of the osteoarthritis. In osteoarthritis, there is deterioration of the articular hyaline cartilage due to the damage of the chondrocytes. Then the bone surfaces become less protected by the cartilage, exposing the nerve endings of the bone. Pain occurs on the weight bearing and mobilization between the two articulating bones. The cartilage degradation products are released into the synovial fluid, causing synovial inflammation, and the inflamed synovium contributes to the formation of the osteophytes at the edges of the joint. Okay, in this figure, we can see properly that in X-ray, we can see the joint space is narrowed, cartilage loss is there, bony spurs or osteophytes are seen. This is a normal knee joint, and this is the osteoarthritic knee joint. Okay. Then as the body tries to repair cartilage, it creates the new material, and these new bony growths are called as osteophytes. In ankylosing spondylitis also, we can see bony spurs in the X-ray images. The bony spurs or osteophytes often form where bones meet each other in the joint, and they can also form on the bones of the spine. The main cause of the bony spurs is the joint damage, which is associated with the osteoarthritis. So osteophytes or the bony spurs is the cardinal symptom of the osteoarthritis. This is the figure which is showing what changes happen in the joint after osteoarthritis. There is loss of joint space, osteophytes formation, subchondral sclerosis, and subchondral cysts. So from the X-ray images, we can note the degenerative changes in the bone, and we can diagnose the osteoarthritis cases. is the gradation of the osteoarthritis. In grade 0, there is no any kind of changes as we have seen earlier. Grade 1 is doubtful osteoarthritis. There is just thinning of the joint space. In grade 2, mild osteoarthritis, exact thinning of the joint space. Grade 3 is moderate osteoarthritis, in which we can observe multiple osteophytes and sclerosis at the joint. Grade 4 is the severe osteoarthritis, in which we can see the large osteophytes as well as severe sclerosis is there, and bony deformity also we can see as Herbenton's nodes or change in the shape of the joint or fingers. Now this was all about osteoarthritis. Now we will go to the rheumatoid arthritis, which is the second most common musculoskeletal disease. Rheumatoid arthritis, it is a systemic inflammatory disease which results in the cartilage and bone destruction. And it is characterized by a typical pattern and distribution of the synovial joint involvement. This organization of the joint leads to the deformities and loss of the function. In the hand, the metacarpophalangeal joints, proximal interphalangeal joints, and thumb interphalangeal joints are most frequently involved. This is the main symptom of the AMAT, as we have seen that in osteoarthritis, mostly the large joints like knee joint, mainly knee joint is involved, but in rheumatoid arthritis, the small joints of the hand and leg, those are mostly involved first. The onset is with the small joints. The distal interphalangeal joints are involved only in the presence of the coexisting MCP and PIP joints. Okay. So tenosynovitis of the flexor tendon causes the reduction in the finger flexion and grip strength. Nodular thickening in the tendon sheath also present, and the hands are affected symmetrically. There is symmetrical joint involvement, and the disease process is usually visible first at the second and third metacarpal phalangeal joints, and the third proximal interphalangeal joints. So this is continuous in the remainder of the MCP and PIP joints. This is the main symptom of the rheumatoid arthritis. So from the acute onset of the disease, we can diagnose rheumatoid arthritis, that which joints are involved in the pathology. So these are the images which are showing the findings we get in rheumatoid arthritis. Mainly, we can see the bone erosion and bone displacement in rheumatoid arthritis, as it is a erosive pathology. We can see in the rheumatoid arthritis, there is bony erosion is the main thing we can note in the X-rays. Okay. So now we will see the common diagnostic signs of the rheumatoid arthritis. In RA, we get mostly stiffness of the joints, and mostly this stiffness is in the morning. It is present in the morning. So morning stiffness, which lasts longer than 30 minutes. This is the main symptom of the Ambat, as in Ayurveda it has been said that in Ambat we have Vrushchik Damshavat Sandhi Vedana, and that also Sanchari. It is the so severe, the pains are so severe like a scorpion bite, and those are the spreading movements, spread from one joint to the another. So that is also a main complaint the patients are having. Then the other symptoms, we can see that swelling, tenderness, decreased range of motion at the joints, and warmth in more than one joint. Warmth in the joint means by Sparshan Pariksha, we can note the warmth or the Ushna Sparshata at the joint in the patients of the Ambat or rheumatoid arthritis. Sometimes some systemic symptoms are also seen, like low-grade fever, loss of appetite, fatigue, then arthritis on both sides of the body, that is symmetrical joints involvement we can see in the RA. At least one positive blood test is in RA we mostly do rheumatoid factor, and the other test is anti-CCP. So in these two tests, at least one test should be positive to diagnose RA. Okay. So arthritis affects small joints of the hands, wrist, and the feet. Symptoms last for at least 6 weeks, and imaging scans show signs of the cartilage erosion and narrowing of the joint space. So these are some images in which we can see the multiple joint subluxations. In one image, we can see the swan neck deformity also as a complication of chronic RA. Right index finger, we can see the swan neck deformity. Then there is also associated periarticular osteopenia, and bone density appears osteopenic for age. The appearance are felt consistent with an erosive polyarthropathy such as rheumatoid arthritis. This is a rheumatoid arthritis of the hand. In this, we can see the ulnar deviation of the MCP joints. The yellow arrows are indicating the cotonear deformity, which is the complication of the RA. Red arrow is indicating the hitchhiker thumb deformity, and the red circle is indicating the area of the affection of the intercarpal spaces. So in this image, we can see the normal joint structure and the bony structure in the osteoarthritis and rheumatoid arthritis. Mostly in osteoarthritis, there is thinning of the cartilage, and bone ends are rubbing together, causing severe joint pain. Okay? And in rheumatoid arthritis, we can see here the bone erosion and swollen and inflamed synovial membrane. These are the main changes occurring at the joint. Now, third one is the rheumatism, or we can call it as rheumatic arthritis. And when it accompanies with the fever, we can call it as a rheumatic fever. So in rheumatic fever, joint pain, stiffness, it is a main chief symptom. So it is an inflammatory disease which can develop when the streptococcal infection in the throat or scarlet fever infection is not properly treated. Streptococcal throat infection and scarlet fever, these are caused by the infection of the Streptococcus bacteria. Okay, generally it affects the children in the age group of 5 to 15, and this is streptococcal infection is very common, but the disease rheumatic fever, which is caused due to streptococcal infection, it is very rare nowadays. Now, in the only the treatment for rheumatic fever is only the injection penicillin, and it don't give any response to the other treatment. It is the only drug of choice in the patient of the rheumatism. So by upashaya, anupashayatmak pariksha also we can diagnose rheumatism or rheumatic fever, rheumatic arthritis cases. Okay. So rheumatic fever can cause permanent damage to the heart, including damaged heart walls and heart failure. And treatment can ease pain or reduce damage from the inflammation, and it can prevent the recurrence of the rheumatic fever attacks. The main symptoms in the rheumatic fever are painful and tender joints. Mostly the joints involved are knees, ankles. Then pain in one joint migrating to the another joint. When the attacks of the rheumatic fever occur in the patients, the joints become very hot, red, and swollen. Apart from these symptoms, the other generalized symptoms are chest pain, fatigue, flat, slightly raised, painless rashes with the ragged edges, heart murmur, then jerky and uncontrollable body movements, which is called as Sydenham chorea, and it is mostly seen in the hands, feet, and face. This is very common sign which is seen in the rheumatic arthritis or rheumatism, Sydenham chorea. So if the patient is having such symptoms, And along with the joint pain, fever symptoms, episodes of the fever and joint pain, we should go for the blood test related with the rheumatic fever, okay? Like ASO titer or 2D echo. Such tests are useful to diagnose the rheumatic fever or rheumatic arthritis. Then outburst of unusual behavior such as crying, inappropriate laughing, which accompanies the Sydenham chorea, and there may be small painless bumps beneath the skin. It is mostly caused due to the infection of the group A streptococcal bacilli. Then along with this, we can see the infections of the skin and other parts of the body also, along with the rheumatic fever and rheumatism, that is joint pain. And the body's immune system mainly targets the infection causing bacteria. In rheumatic fever, the immune system attacks the healthy tissue, especially in the heart, joint, skin, and the central nervous system. And this faulty immune system reaction results in the swelling of the tissues or inflammation of the joints. Okay. So, if it is treated, if the early attacks of the streptococcal infections are treated properly with the antibiotics, then we can prevent the patients to develop rheumatism or rheumatic fever. Then the next most common type of arthritis is the gout arthritis, gouty arthritis. It is very common and complex form of arthritis which can affect anyone. Mainly it is characterized by the pain, swelling, redness, tenderness in one or more joints and mostly big toe. The big toe affects first in this pathology. So attack of gout can occur suddenly in the night with the sensation that big toe is on the fire. Like there is so severe pain, like burning type of pain, as it is mentioned in Ayurveda also, Mushakadamshavad Sandhi Vedana. The pain is like, it is very severe and burning kind of. The affected joint is very hot, swollen, and so tender that even the weight of the bedsheet on it may seem intolerable to the patient. And the gout symptoms may come and go. The symptoms may exaggerate, or they may be become less in the patient, and it can flare up also according to the favorable conditions, and sometimes the patient may subside also. This is a common type of the Vataja Vikar. As we know in Ayurveda also, it has been said that the wave of Vata Vyadhi, mostly in Vegavastha, most of the symptoms are exaggerated, and in Avegavastha, all the symptoms are subsided. So this is the common group or common lakshan of the Vata Vyadhi. And in gout also, it is given that such kind of pattern is seen. Now, if we see this image in the joint X-ray, X-ray of the joint, we can see the uric acid crystals. So, from the X-ray, we can diagnose gout arthritis. In not all cases, but in the complicated or severe cases, in the patients in whom the uric acid is elevated up to the very large content. So in that patient, we can see the uric acid crystals in the joints, affected joints, and the toffee is also. Toffee is also one of the symptoms which is seen in the gout arthritis. The signs and symptoms in the gout are intense joint pain. Generally, gout mostly it affects the big toe, but it can also occur in other joints also. The other commonly affected joints are ankles, knees, elbows, wrist, fingers. The pain is very severe, which is very much severe in the first hour to the 12 hours when it begins. Then the lingering discomfort is also the chief symptom in the gout. After the most severe pain subsides, some joint discomfort may last from a few days to the few weeks. So later attacks are likely to last longer and affect more joints There is inflammation and the redness in the joint. Limited range of motion is also seen in the patients of the gout. So what are the causes of the gout? In this picture also we can see the crystals of the uric acid in the joint area. So gout occurs when the uric crystals accumulate in the joint, causing inflammation and intense pain of the gout attack. Uric crystals can form due to the high levels of the uric acid in the blood. The body produces uric acid when it breaks down into the purines. And purines are also found in certain foods, including red meat, organ meat, such as liver, etc. So the patient consuming such kind of food, they may get purine in high content in their food. Other hetus or other etiological factors like alcoholic beverages, beer, drinks sweetened with the fruit sugars, they can also promote higher levels of the uric acid. So normally the uric acid dissolves in the blood and it gets excreted through the urine. It's filtered through the kidney and excreted through the urine. But when the body produces too much uric acid, or kidneys are not able to excrete the uric acid, then what happens? It builds up into the blood and it forms the sharp needle-like uric crystals in the joint and issues causing pain, inflammation, and these are the X-ray images in the gout arthritis. In gout arthritis, there is loss of joint space and sclerosis. Mostly they are present predominantly in the MTP joints of the big toe. The large defects of the head of the metatarsal bone of the first toe are caused by the gout trophy. So this trophy we can see. Frontal and oblique radiographs of the foot demonstrating amorphous calcification next to the metatarsal head in a patient with gout. Calcified soft tissue tophus must be considered. Now, for diagnosis of the gout arthritis, along with the blood test, we go for the serum uric acid. So, in most of the patient of the gout arthritis, serum uric acid level is exceeded. Then second one is the X-ray imaging. In joint X-ray, as we have seen earlier, we can see the trophies or the uric acid crystals deposition. Then third test is joint fluid test. In the fluid which is accumulated into the trophies, or if there is inflammation at the joint, we can take the aspirated joint fluid and we can go for the chemical, physical, and microbiological and microscopic examination of that fluid. In that, we can come to know about the correct diagnosis. Now, these are three images which are showing the difference between osteoarthritis, rheumatoid arthritis, and gout. Again, I am telling you that in osteoarthritis, we can see joint pain, arthritis, and subchondral sclerosis. Then in rheumatoid arthritis, soft tissue swelling, ill-defined marginal erosions, loss of the joint space, and periarticular osteoporosis. Okay, and in gout, we can see asymmetrical soft tissue swelling, well-defined periarticular erosion, and bony hooks. Okay. The next type of arthritis is psoriatic arthritis. Psoriatic arthritis is followed generally by psoriasis. Psoriasis is a systemic disease, and in the chronic psoriatic patient or untreated psoriatic patient, the patients may get psoriatic arthritis. It can cause several different symptoms around the body. Some of the chief symptoms of the psoriatic arthritis are the joint pain. The joint pain is a along with the joint pain, there is swelling also in one or more joints. There is joint stiffness, which feels worst when the patients get up after rest and last longer, more than 30 minutes. This is also known as the inflammatory arthritis, and any joint can be affected in this kind of disease. This is also an autoimmune disease. It is an autoimmune disease with known human leukocyte antigen, that is HLA associated risk factors. It affects the ligaments, tendons, fascia, and joints, and it occasionally develops in the absence of the detectable psoriasis. So it always there with the systemic psoriasis. Psoriatic arthritis may also occur at higher frequencies when the skin involvement is more severe, especially in the pustular type of psoriasis. So the chief symptoms of the psoriasis are swollen fingers and toes. Foot pain is there. In foot pain, generally, we get tendonitis at the back of the heel, that is Achilles tendon and plantar fasciitis. These are two tendons which are most commonly affected in the psoriasis. Along with that, we get lower back pain, that is spondylitis and sacroiliitis. Nail changes are also there. Nails can form tiny dents or pits and crumbles, and also they can separate from the nail beds. This is also the common symptom of the psoriasis. This is called as dactylitis. Okay. Sometimes along with all these symptoms, there is eye inflammation also, uveitis, and it can cause eye pain, redness, blurry vision, and if it is kept untreated, it can also lead to vision loss. So in psoriasis, we get other symptoms like skin lesion, and along with that, we get arthritis also. The inflammation in the connective tissue, which is known as enthesis, which attach tendons and ligaments to the bones. And when there is inflammation, that condition is called as enthesitis. Okay? It can spread over the wide area rather than just inside the joint. Okay? The affected areas can feel tender if we touch them by the sparshan pariksha or sparsha sahatva lakshan. We can see at the joint. And pidana sahatva also we can feel sparsha sahatva and pidana sahatva. Sparsha sahatva means by touch also the patient feel the pain, and by pressure also the patient can feel pain. That is sparsha sahatva and pidana sahatva. These two exams are positive in the psoriatic arthritis. Generally, it occurs at the feet, that is the back of the heel and bottom of the foot near the heel. If we see the X-ray images in the psoriatic arthritis, mostly a very common cup and pencil deformity of both the thumbs and erosion of the DIP joints, the left middle finger. Cup and pencil type of deformity is mostly seen in the psoriatic arthritis, that is erosion of the one end of the bone with the expansion of the base of the contiguous metacarpal. So this kind of deformity is mostly seen in psoriatic arthritis. It almost always accompanies the skin diseases, especially nail changes. It involves DIP joints of the hands more than feet, and classical cup and pencil deformity is also seen in the X-ray findings. If we observe this image, we can see the ankylosis of numerous proximal and distal interphalangeal joints, which is shown by the white arrows. Flexion deformities and lack of significant osteoporosis. Then there is also a reabsorption of the terminal phalanges, and mostly osteoporosis is not seen in the psoriatic arthritis. Okay. In this patient, HLA-B27 blood test is positive, RA factor is negative, and it tends to involve smaller joints of the hands and the foot than the larger joints. Asymmetrical joint pain involvement is there, and mostly it affects both the juxta-articular and articular margins of the joints. So other imaging tests related with these diseases are X-rays and MRI of the affected joint. Now in this figure, we can see the symptoms of osteoarthritis, rheumatoid arthritis, psoriatic arthritis. In osteoarthritis, there is stiffness with activity, sclerosis of the joint, bony spur formation, joint space narrowing is seen. In psoriatic arthritis, there is no osteoporotic changes, but there is nail dystrophy, sacroiliitis, ankylosis, dactylitis, and enthesitis. These are all symptoms. Conditions are seen in the psoriatic arthritis and in rheumatoid arthritis. There is symmetrical peripheral joint involvement, bony erosion, proximal involvement, and destructive bony lesions are seen. This is again the figure showing the difference between RA and OA. Okay, mostly we can see erosive pathology, inflammation, swelling. In the rheumatoid arthritis, symmetrical joint involvement is there. And in OA, there is loss of articular cartilage, bones are rubbing together, degenerative changes are seen, and there is asymmetrical joint involvement. In symptoms, we can see the joint pain, stiffness, and inflammation in the rheumatoid arthritis, morning joint stiffness which lasts more than 30 minutes, and in osteoarthritis, pain and stiffness in the movements, morning stiffness which lasts more than 30 minutes. The next disease which also has joint pain as a chief symptom is the Ankylosing Spondylitis. It is a very rare type of arthritis, but it causes pain and stiffness in the spinal region. This is a lifelong condition and it is also known as the Bech-Tero disease. It usually starts in the lower back and then it spreads up to the neck and it joins in the other parts of the body. So ankylosis is the fusion of the bones or other hard tissues, and spondylitis is the inflammation in the spinal bones or the vertebrae. Okay. Severe cases can also leave the spine hunched in the patients having AS. Mostly it starts at the sacroiliac joint of the spine, and it can also affect the places where tendons and ligaments are attached to the bones, and it can even cause vertebrae to fuse together. This all fusing makes the spine less flexible, or it is also called as bamboo spine. Means the spine becomes very rigid, it is less flexible, and it can result in the hunched posture. And when the ribs are also affected in this disease, the patient can have the symptom like breathlessness or dyspnea. This disease is mostly seen in men rather than women. The signs and symptoms typically begin in the early adulthood. Inflammation can also occur in the other parts of the body, in eyes also, and the pain is worse in the morning or after sitting for a long time. The rigid spine curves forward. There are other symptoms like tiredness, trouble taking deep breaths, or breathing problems also can be seen in the patients of the ankylosing spondylitis. So this we can see the posture of the patient having AS. The vertebrae are fused. We can see the normal vertebrae in the image and the fused vertebra in the case of AS. Along with other symptoms, neck pain, fatigue, these symptoms can also be seen. The ribs, hip, shoulder joints, all joints may be affected after the spinal joints. Okay. Now, there is no specific cause of the ankylosing spondylitis, though genetic factors seem to be involved. In particularly, people who have a gene called HLE-B27, those are at high risk of developing AS, and other people not having this gene can also develop this condition. The symptoms may differ from person to person. The main symptoms in ankylosing spondylitis are eye inflammation, that is uveitis, compression, fractures, and cardiac diseases. Also, the aortic diseases can also occur in the patient of the AS. Then the next autoimmune disease, which is related with the arthritis, is the SLE or systemic lupus erythematosus. This is also autoimmune disease. In this, in autoimmune diseases, the body mistakenly attacks the healthy tissues, and then the symptoms start occurring. Many systems are involved in SLE, like cardiovascular system, respiratory system, skin diseases also are there, swelling, arthritis. And in arthritis, typically, mostly in SLE, the affected joints are of the fingers, hands, wrist, and knees. So in this figure, we can see that many systems are involved in the SLE. Skin is affected. We can see the butterfly rash or red patches on the skin. There are some symptoms like endocarditis, atherosclerosis, and inflammation of the fibrous sac, which are related with the heart. Patient can also feel the severe abdominal pain. Blood-related some symptoms like anemia, high blood pressure are also seen in SLE. In muscles and joints, the patient may have pain. Joints are swollen. Along with that, other systemic symptoms like hair loss, high-grade fever, abdominal pain, headache. These symptoms are also seen. Urinary is also get involved. Patient may have hematuria like symptoms. Respiratory system is also affected. The patient may have symptoms like pleuritis, pneumonitis, pulmonary embolism, pulmonary hemorrhage, and ulcers in the mouth and nose. These also can be seen in the patient of SLE. Lymph nodes may also get swollen. So as we see, there are diseases of the brain, nervous system, gastritis, abdominal pain, nausea, vomiting, pericarditis, like valvular problems, inflammation of the heart muscle or heart lining, that is pericarditis. Respiratory system is also get involved. There may be buildup of fluid in the pleural spaces, difficulty breathing, coughing, blood, skin problems. Patient may be having nephritis. Also, some patient may face, and circulatory problems like clot in the veins, arteries, thromboembolism, or such kind of symptoms are seen. Called phenomenon. Raynaud phenomenon means in the veins, inflammation of blood vessels, constriction of the blood vessels in response to the cold. So this kind of phenomenon is seen in the SLE. Blood abnormalities including anemia, low WBC platelet count, and some people have only skin problem, not the joint problems, and that condition is called as discoid lupus. So in this diagram, we can see the butterfly rash on the skin in the patient of the SLE. The most common test, which is blood test, which is positive in the patient of SLE is ANA test, that is anti-nuclear antibody. Okay, but not all patients having ANA positive will have SLE. So this also we have to remember. Then the next type of arthritis is tubercular arthritis. We will go to the next type. Tubercular arthritis is mostly followed by the extrapulmonary tuberculosis, which is not properly treated, and if it is chronic, it arises on the background of pulmonary tuberculosis as indolent chronic monoarthritis, and often in the joint of the knee or wrist, and eventually results in the extreme destruction of the joint and the surrounding bones. Okay. It results from the endogenous reactivation of the foci of infection seeded during the basilemia. It spread to the paravertebral lymph nodes, and then it gets localization in the spinal area, which can result in the spinal TB. And from spinal, it may go to the lower thoracic and upper lumbar vertebrae. Okay. So it is also postulated that the predilection of the TB to localize in the metaphysis of the long bones due to the relatively rich blood supply and scarcity of the phagocytic cells in this portion of the bone. After beginning in the subchondral region of the bone, the infection may spread to involve the cartilage, synovium, and joint space. It produces the typical findings of the metaphyseal erosion, cyst, loss of cartilage with the narrowing of the joint spaces, and in the spine, these changes involve to adjacent vertebra and the intervertebral disc. Now, in this figure, we can see the radiological findings in the tubercular arthritis. There is a Femister triad, which was named after the American orthopedic surgeon, Dallas Femister. So this Femister triad is seen in the patient of the tubercular arthritis, and this triad has three main symptoms, that is juxta-articular osteopenia or osteoporosis, peripheral osseous erosion, and gradual narrowing of the joint spaces. So in the X-ray or CT scan or MRI of the bone, we can see this Femister triad, and from that we can diagnose the tubercular arthritis. Even if the fluid in the joint effusions is checked for the pathological test, we can identify, and if ZN staining, the test for the tuberculosis staining is done, we can identify the tubercular arthritis of the bone. Now the next type of arthritis is the reactive arthritis. Reactive arthritis is also known as the Ritter's disease. There is joint pain and swelling which is triggered by the infection in other parts of the body. Most often, the infections of the intestines, genitals, and urinary tract. This condition usually targets the knees, ankles, feet. Inflammation can also affect the eyes and the urethra. This reactive arthritis, in which three common symptoms are there: conjunctivitis, urethritis, arthritis. Okay. Actually, it is associated with the immune response to the enteric or genitourinary bacilli, that is Shigella, Salmonella, Yersinia, and Chlamydia infection. HLA-B27 test is positive. The chief symptoms are conjunctivitis, that is discharge, erythema, burning, and photophobia. Second most important symptom is urethritis, that is dysuria, urgency, frequency, and discharge. And third important symptom is the arthritis of the knees, ankles, and the feet. Now, up till now, we have seen the many types of arthritis, that is osteoarthritis, rheumatoid arthritis, rheumatic arthritis, psoriatic arthritis, tubercular arthritis, SLE, ankylosing spondylitis, and Ritter's disease, or the reactive arthritis. Okay. So, how to do the differential diagnosis of the patient having joint pain? If the patient is having typical symptoms and radiographic features described, the diagnosis of the osteoarthritis is straightforward and is unlikely to be confused with the other entities. But in less straightforward cases, other diagnoses should be also considered, like if periarticular structure is there, periarticular pain that is not produced by the passive motion or palpation of the joint, should suggest an alternate etiology such as bursitis, tendonitis, or periostitis. Some inflammatory arthritis, if the distribution of the painful joints include metacarpophalangeal joints, wrist, elbow, ankle, shoulder, there is less possibility of osteoarthritis unless there are specific risk factors such as occupational, sport related, or history of injury. Prolonged stiffness. If the stiffness of the joint is greater than 1 hour, it raises the suspicion of the inflammatory arthritis like rheumatoid arthritis. The marked warmth and erythema of the joint suggest a crystalline etiology such as in gout arthritis. Then arthrocentesis, that is aspiration of the joint fluid, can help in distinguishing between these types of arthritis if the diagnosis is not clear by the history, physical examination, and the radiographs. If there is any suggestion of an infected joint, it should be aspirated. The fluid should be sent for the culture testing also. The other inflammatory systemic conditions like weight loss, fatigue, fever, loss of appetite suggest the systemic illness such as polymyalgia rheumatica, rheumatoid arthritis, or SLE, or sometimes malignancy. Now, these are all investigations which are related with the which should be done in the patient of the arthritis, not all, but according to the clinical examination of the patient and its condition or severity of the symptoms. Now, these all tests are okay, used to rule out the different kinds of arthritis. The first one is ESR, RA test, anti-CCP, ASO titer, anti-nuclear antibodies, C-reactive proteins, HLA tissue typing, Lyme serology, uric acid, and joint fluid examination and the culture. Along with that, X-ray, MRI, CT scan also important diagnostic radiological investigations. Now, erythrocyte sedimentation rate, that is ESR. Generally, its normal range is 0 to 20, but it may get raised in the patient of rheumatoid or rheumatic arthritis. Second one, important investigation in the patient of arthritis to rule out all types is rheumatoid factor. This rheumatoid factor level measures the level of RF, which acts as an antibody against gamma globulins, which is a type of normal protein in the blood. Normal range is 0 to 20 units per ml. The higher level of RF might point to RA, but this alone does not confirm the presence of the condition. Several other health conditions can also show the increased levels of rheumatoid factor in the body. Okay, some other autoimmune diseases, then musculoskeletal diseases also can show RA positive. Around 20% of the people who have RA positive do not have high levels of RF. 20% of the people which are clinically having rheumatoid arthritis, they don't have higher levels of the rheumatoid factor. So along with RF, we need other tests also like anti-CCP test to confirm the diagnosis. Then in some cases, certain viruses can also trigger symptoms similar to those of RA and lead to the positive rheumatoid factor test results. Like viruses, this type of infection include the parvovirus B19 and hepatitis C virus. So the recognition of the antibodies directed against citrullinated peptides in RA has been a major development to improve the disease identification and provide prognostic information. Citrullation is a normal process required for normal skin formation and other physiological functions. In rheumatoid arthritis, an autoimmune response develops against citrullinated peptides detected as anti-citrullinated peptide antibodies, that is ACPA. This test looks for the specific autoantibody called anti-cyclic citrullinated peptide. About 75% of people with RA will have anti-CCP if a person has RA and anti-CCP antibodies, they have a seropositive RA. That is called as, if in the patient RA and anti-CCP antibodies are present, it is called as seropositive RA. Otherwise, it is seronegative RA. Okay. To interpret the results, we have to look at the rheumatoid factor test, and we have to also do clinically. We should also clinically correlate the patient. If the both RA and anti-CCP may be positive or negative, but clinically examination can confirm the diagnosis. The positive CCP antibodies and positive rheumatoid factor, the patient likely has RA. Positive CCP antibodies, negative RA, the person has early stage of RA or may likely to develop it. Negative CCP antibodies and negative RA, lower chance of developing RA, and the normal range of the anti-CCP is 0 to 20. If it is more than that, they may have rheumatoid arthritis. Then the next important investigation is ASO titer. It measures the antibodies produced by the body in response to a toxin known as streptolysin O. It is a toxin produced by the group Staphylococcus A group bacteria, that is gas. Some of the common infections of the streptococci bacteria are bacterial endocarditis, glomerulonephritis, and rheumatic fever. The anti-streptolysin antibodies peak in the system between 3 to 8 weeks after the infection, and the levels may remain high for the several months. The value should be below 200, and in the children under the age of 5, it should be up to 100. And ASO positive test may be indicative of rheumatic arthritis. Okay. So anti-nuclear antibodies are the autoantibodies bind to content of the cell nucleus. In a normal individuals, the immune system produces antibodies to the foreign proteins, but not to the human proteins, that is autoantigens. So this test looks for the high levels of the anti-nuclear antibodies, and these are the blood proteins which can attack a cell's nucleus, destroying the whole cell. So this can be present in people with a number of conditions like rheumatoid arthritis, scleroderma, Sjogren's syndrome, and mixed connective tissue diseases. So a positive result of an ANA test alone cannot confirm that RA or rheumatoid arthritis is present. It may be present in many autoimmune diseases. Okay. So ANA may be positive in SLE, Sjogren's syndrome, the disease that causes the dry eyes and mouth, scleroderma, connective tissue disease, rheumatoid arthritis, polymyositis, that is the disease that causes muscular weakness. Now, next important investigation is CRP, that is C-reactive proteins, which the liver produces in response to the inflammation in the body. It is an inflammation marker. The protein helps regulate immune reactions, and the results of the CRP test can indicate the systemic inflammation. The presence of CRP can indicate the inflammation anywhere in the body, and a positive test result may indicate rheumatoid arthritis or another condition like diabetes, obesity, metabolic syndrome, heart diseases, depression, or lung diseases. Okay. Then HLA, human leukocyte antigen tissue typing. Some studies suggest that around 60% RA cases may be inherited. If the person has specific antigens, it could mean that they have a higher likelihood of developing RA. However, other factors like tobacco use can also trigger the condition. HLA markers in the blood can help indicate the likelihood of developing an immune-related conditions like RA. These markers may also be the sign of another condition like Ankylosing Spondylitis or reactive arthritis. The next is Lyme serology. The symptoms of Lyme disease are mostly similar to the rheumatoid arthritis. Lyme serology detects the presence of antibodies which indicate the Lyme disease, and the person has Lyme serology immune factors. It may mean that they have Lyme disease rather than RA. The next important investigation is uric acid levels. It is a waste product that tends to be present in the high amounts when a person has gout, which is another form of inflammatory arthritis. The person typically has a high level of uric acid, also known as hyperuricemia. Now up till now, we have seen many blood tests, the radiological investigations like X-ray, CT scan, MRI of the joint. And along with that, we can do other diagnostic tests also. Beyond blood tests, the following factors can help the doctors make rheumatoid arthritis diagnosis. Fluid samples that look for the uric acid crystals or other compounds. Imaging studies suggesting the damage to the joints reveal fluid-filled areas around them, and receiving a prompt diagnosis is the key. Getting early treatment can help slowing the progression of the condition. Now, this is the synovial fluid examination in the patient of arthritis or knee effusion or joint effusion patient. We can aspirate the joint fluid and we can examine it physically and other count also in this patient. Like for example, in this chart, I have shown that generally in the patient of osteoarthritis, the color is yellow. In SLE, straw color is there. Rheumatoid arthritis also yellow color. In gout, there is mostly yellow to milky color. TB arthritis, yellow colors. Septic arthritis, gray or bloody color. Then what is its appearance? What about the WBC count? Mostly WBC count is highly raised in the tubercular arthritis, septic arthritis, rheumatoid arthritis. In all inflammatory pathology, the WBC count is increased. Okay. The crystals in pseudo gout, we can see the calcium pyrophosphate crystals, and in gout we can see the urate crystals. And when we think about the bacteria, by staining the slides, the pathological pyogenic examination of the fluid in tubercular arthritis, mostly tubercular bacilli is present, which can be found out by ZN staining, and in septic arthritis, the other pathogenic bacteria can be present. In culture studies, we can confirm the bacteria, the resistance and sensitivity to the specific drugs. Now, this is also fluid examination slide. According to the diseases, inflammatory pathology, non-inflammatory pathology, the arthritis related with the gonococcal infections, bacterial non-gonococcal infections, and Lyme disease. So in this also we can see that how the color, appearance, WBC count, by staining method we can get the proper diagnosis of the specific type of arthritis. So up till now we have seen all the differential diagnosis of the Ayurvedic point of view, the modern diagnosis of the arthritis, and various tests, pathological, hematological, and radiological tests in the examination in the patients of the arthritis, fluid examination. So I think this is enough for the students, this information. And with this, I declare that I have completed my lecture. Thank you very much. Fully, sir.
Thank you, ma'am.
Huh.
Yes. Hello.
Hello, sir.
हाँ मॅम, कोणाला काही प्रश्न विचार, anyone have any doubt regarding today's lecture or want to ask something or any add-ons? Hello. Anand More sir is have also joined there. I request him to give some inputs. Hello.
Hello, sir.
Hello.
Yes, sir. Good
बोला ना, sir.
Dr. Archana Madam has covered almost all the points and all the conditions of the Sandhi shool and inflammation. And Madam has been elaborately covered all the investigations, even though there is special investigations also. I think there is no problem in understanding this after this lecture. So I congratulate Madam for taking this topic elaboratively. And I think most of the who are listening may not have any problem for understanding this topic.
Yes. Sir.
Thank you, Ganesh.
Yes, sir. Thank you, sir. Thank you, respected Anand More sir. Very elaborative lecture actually, ma'am. जैसा मैंने सुना था कि मैम टीचिंग में स्टूडेंट फ्रेंडली होती है, तो आज एक एक पॉइंट लिटरली आई नेवर थॉट कि संधि शूल के बारे में इतनी जानकारी हो सकती है. सो आई एम वेरी थैंकफुल टू मैम. और इतने शॉर्ट नोटिस पे मैंने मैम को मंगलवार को फ़ोन किया था, जो डेजिग्नेटेड हमारे स्पीकर थे वो उनका टाइम पे कैंसिल हुआ, तो मैम ने इतनी शॉर्ट रिक्वेस्ट पे हमारा एक्सेप्ट किया. सो थैंक यू वेरी मच मैम.
Thank you, sir.
Yes. I
Thank
again
you.
ask if any student or any participant have any questions or doubt, can ask to the madam, or otherwise we will conclude this lecture.
Thank you very much, sir. I think
Yes, ma'am.
nobody is having any problem, queries. So
Any query or something like a coach? ऐसा ठीक है मैम. Okay.
thank you, sir, for giving me opportunity to the Nidan Parishad family.
Thank you.
And you also.
Yes. Shall we conclude, ma'am, now?
Yes,
Hello.
we can leave.
Yes. Yes,
हाँ,
ma'am.
हाँ,
Thank
sir.
you, ma'am. Thank you.
Okay, sir.